Good afternoon or good morning to those of you who are joining us remotely from other time zones. I'm David Rousseau of KFF, formerly known as the Kaiser Family Foundation, and on behalf of the GIH board and staff, I have the amazing privilege today of introducing this year's Terrance Keenan Leadership Award winner, Dr. Janet Yost, former president and CEO of the Health Foundation of Central Massachusetts. But first, I'd like to offer a special thanks to this year's selection committee, each of whom dedicated their time and energy to reviewing yet another great slate of nominations. Joining me on the committee were Patty Baum from New Hampshire Children's Health Foundation, Judy Belk from the California Wellness Foundation, Rose Green from the Colorado Health Foundation, Irfan Hassan from the New York Community Trust, Carl Lavender from the Foundation for a Healthy St. Petersburg, Barbara Leonard from the Maine Health Access Foundation, and Lisa Medellin from the Healthcare Georgia Foundation. I'd like to thank each of them for their time and commitment to GIH and to our field and for participating in selecting this year's winner. I'd also like to thank GIH's fearless leader, Kara James, who joined our deliberations this year, and to Ann McMillan, who supported the committee's work. Each year, the committee has a difficult task of selecting from among a strong field of nominees a person whose work embodies the leadership, innovation, and achievement Terrance Keenan championed during his 4 decades of service to our field at the Robert Wood Johnson Foundation. In addition to these 3 pillars, the criteria the selection committee considers include the nominee's responsiveness to the people in their communities, large or small, and in particular, their responsiveness to those in the greatest need. The award is designed to recognize a leader who is distinguished by her creativity, risk-taking, and boldness. If you know someone who you think is deserving of the recognition Janice is receiving today, please consider nominating them for next year's award. Janice is probably one of the few people in the nation who's been the founding president of not one, but 2 different health conversion foundations, which is both a remarkable testament to her skill and commitment to the field, and also potentially its own DSM code. It's also noteworthy that she did so in 2 very different communities, first in South Carolina and then in Massachusetts. As someone who grew up in Louisiana but who later lived in New England, I can relate to the challenges of navigating the very different community, culture, and political dynamics in those 2 places. Janice launched her career in health philanthropy as a volunteer board member of the Spartanburg Hospital System and the South Carolina Association of Hospital Governing Boards, where she showed really early signs of the skill and accomplishment that would become the hallmark of her career. She chaired a statewide task force for smoke-free hospitals that led to South Carolina's hospitals becoming the very first in the nation to go smoke-free back in 1989. She did this while serving as Associate Chancellor of the University of South Carolina, Spartanburg, excited by the health impact she saw through her work and seeing how it could impact communities, and willing to take the kind of risk that the Terrance Keenan Award is designed to reward. She left her tenured faculty position to become the founding president of the Mary Black Foundation in South Carolina, and then took the lessons from that experience and helped establish yet another health conversion foundation at the Health Foundation of Central Massachusetts. Janice served for more than 2 decades in Massachusetts, where she was an innovative force in promoting systems-level advocacy, focusing on building lasting community collaborations that supported and listened to community leaders rather than imposing foundation priorities on the community. Among her many accomplishments, she convinced the board and the Massachusetts Attorney General that the new foundation she was leading should maintain its C4 status that it formerly enjoyed as a health plan, while also creating a C3 affiliate. This enabled the foundation under Janet's visionary leadership to focus on advocacy and lobbying efforts related to a wide range of public policy impact through the C4, while also using the C3 for activities ranging from serving as a fiscal sponsor for the community organizations to working to an intermediary for other foundations who couldn't fund programs directly. Janice also spearheaded the development and use of novel approaches to evaluating the impact of the work her foundation was doing, which had been adopted and emulated by so many others in the field. She was also a pioneer in letting the community drive the health agenda, leading the development of many cross-sector collaborative efforts that were sustained in the community, looking at emergent issues in the region. These included successful efforts to address homelessness and transportation issues well before many other foundations had turned their focus to these social determinants of health. Janice has been a leader in our field in so many respects, not only by innovating at the 2 conversion foundations she led, but by mentoring so many others, both formally and informally, across our entire sector, as well as within her own staff. I didn't have the opportunity to get to know Terrance Keenan, or Terry Keenan as his friends called him, but several friends and colleagues of mine did, and I felt like I've gotten to know him a little bit during my tenure chairing the selection committee. This is my last year serving on the committee, and it's actually my first being able to give the award to someone in person, which is really special to me. And I couldn't imagine giving it to someone more deserving than Janice. I think Terry was way ahead of his time in encouraging grant makers to focus more people and communities and to look at how leaders took risks and thought about how they could impact their community through philanthropy. And Janice embodies all those spirits. So without further ado, I'd like to welcome Janice up to the podium, and please join me in congratulating her on winning this year's Terrance Keenan Leadership Award. Janice.
Thank you for your very kind words, David. Having been involved with GIH since 1996, including attending several of these awards luncheons, I'm deeply honored and humbled to receive the Terrance Keenan Leadership Award in Health Philanthropy. Many of you may recall from your British literature studies that Robert Browning was a poet who lived in the 1800s and is best known for dramatic monologues and introducing blank verse rather than the traditional rhyme scheme. Robert Browning's father was a wealthy banker and his mother was a devout nonconformist, witnessed among other views her evangelical faith, which prevented her son from being able to attend Oxford or Cambridge, where at that time only members of the Church of England were accepted. So he was tutored at home using his father's huge library. No doubt influenced by his mother, Robert Browning identified as a liberal, supporting the emancipation of women and animal rights, while opposing slavery and anti-Semitism. He lived at home until the age of 34, when after a romance developed through correspondence, he married Elizabeth Barrett, who is best known for her love sonnets. Elizabeth was 40 and had also only lived at home. Because her father disapproved of any of his children marrying, he disavowed her, and the couple moved to Italy. It is believed that Elizabeth was the intended main audience of Robert's poetry, and that her deep Christian faith strengthened Robert's, shaping his poetry and one of his most memorable lines. "Ah, but a man's reach should exceed his grasp, or what's a heaven for?" Were he alive today, Robert Browning would likely encourage GIH and health funders to reach beyond our current grasp and to focus on more impactful grant making. GIH has asked me to reflect on my work and to offer my advice to this audience. In so doing, I want to preface my remarks by explaining that my 25 years of experience as a health funder, with two, as David explained, two health conversions being formed in the mid-1990s and late 1990s. Both foundations had a local service area focus and began with $60 million in assets. Incidentally, that amount approximates the median size of nearly half of all the conversion foundations in the country. So these characteristics represent a sweet spot of GIH members. In full disclosure, my advice may sound like I think I know it all. I am pleased that my 68-year-old baby brother has joined us today. Growing up, he was way more special to me than even my Barbie doll, and I doted on him, teaching him everything I knew. Unfortunately, my unsolicited teachings have persisted in adulthood, and rightfully so. He can become frustrated at times and respond with, "You think you know everything." So please, my colleagues, will you affirm that everybody knows that funders do know everything? Can I get an amen? I'm also pleased that some of my work family are here today. Their dedicated service certainly contributed to the Health Foundation's recognition and to my receiving the Keenan Award. I'm deeply grateful to you. I can barely see you. There you are. Supporting the conference theme of better health through better philanthropy, my advice to GIH and health funders is that rather than following the path of traditional philanthropy, that being focused on program grants, I invite you to consider reaching beyond our grasp in 5 ways. 1, accept the broad definition of health. 2, deepen community engagement. 3, increase the size and duration of grants. 4, emphasize an evaluation component. And 5, support advocacy that leads to systems change. Consideration 1. Thank you. Consideration 1, accept the broad definition of health. Like others who founded conversions, the Health Foundation undertook a strategic planning process to determine our grant-making agenda in 1999. We quickly realized that an annual grant-making capacity of $2 to $2.5 million would, at best, only cover a rounding of the regional hospital system's bottom line. So wanting to maximize the impact of our grants, we chose to adopt the World Health Organization's broad definition of health, established in 1946, as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This key decision at the outset predated the CDC's release in 2010 of the Health Impact Pyramid, which brought a public health lens to interventions to address the social and economic determinants of health. This key decision enabled our grant-making to go upstream by addressing the underlying causes of poor health, reaching beyond the delivery of health care. Dr. Doug Easterling, a researcher at Wake Forest School of Medicine, received a grant from the Robert Wood Johnson Foundation to study 240 health conversion foundations. In 2017, he identified the Health Foundation as one of 33 innovative conversions that had given attention to the social determinants of health. One of our earliest initiatives, called Together for Kids, developed a model intervention where, with an average of 24 hours of behavioral health consultation with teachers and parents to address preschool children's challenging behaviors, expulsions were reduced to near zero, and children entered school academically ready to learn. Advocacy efforts have led the state of Massachusetts to provide over $24 million from 2007 and continuing today for behavioral health consultation services in preschool settings across the state. Our support for Together for Kids totaled about $1.8 million from 2001 to 2009. Consideration 2, deepen community engagement. Another atypical element in creating the Health Foundation's grant-making agenda was the decision that the board would not identify specific health issues as our funding priorities, but we would instead rely on leadership, stepping forward from the community to identify a serious health issue and demonstrate that a collaborative was in place to address the issue. Given the varying needs of the region and the nonprofits' concern that their needs be addressed with the Foundation's new assets, this decision was well received. Moreover, much like the canary in the coal mine, it has enabled emergent issues, often lacking up-to-date state data, to be addressed. For example, in our initial call for letters of intent, we were surprised in 2000 to receive 2 community-led proposals in different parts of the region to address the serious lack of dental services and its negative impact on physical health. The state at that time was not collecting oral health data. We listened and provided $6 million over 11 years to 2 projects to address the oral health crisis. In addition to providing support for increasing the number of dental chairs at community health centers, expanding training of dental hygienists, and engaging dentists in private practice, the project's advocacy led to system changes in the administration of Medicaid dental benefits, increased reimbursement rates, and greatly expanded benefits totaling untold millions over the years. A few recent articles in the Chronicle of Philanthropy have urged foundations to cede power to help those it seeks to help, noting that even as boards are becoming more diverse, the top-down management style does not champion the community's voice in setting grant-making priorities. Our experience is that we can cede power while maintaining fiduciary responsibility. Consideration 3, increase the size and duration of grants. The Chronicle of Philanthropy presented a Bridgespan Group report in December 2019, which concluded that the average duration of grants made by the country's largest foundations was less than 18 months with a median grant of $50,000. This track record begs these rhetorical questions. How many societal or health issues can be solved with $50,000 in 18 months? Why do foundations continue to fund programs that typically end when the grant ends? Intractable issues require more money and time. The Health Foundation has 2 funding avenues. Approximately 70% of the grant making is done through our Synergy initiative, which typically provides $2 to $3 million to each of 4 projects over 5 or more years. The funding begins with a planning grant, then a pilot grant, which is followed by years of intervention support, including an emphasis on evaluation and advocacy to create systems change in order to institutionalize the intervention. Consideration 4, emphasize an evaluation component. The Health Foundation has been recognized for its outsized reach with an evaluation approach that engages professional evaluators as grant project partners. Capturing evidence of grant outcomes requires sophisticated evaluation and is essential for improving philanthropy and health. We use a results-oriented grant-making model, which I co-developed with Dr. Abe Wandersman, a professor at the University of South Carolina. The model is a universal problem-solving approach, which includes 10 accountability questions that are embedded in our applications, process evaluations, and summary reports. We devote 10 to 15% of our Synergy Initiative funding to each project's evaluation component, an amount that is well beyond philanthropy's practice. The model involves the hiring of a professional evaluator for each project, from the application phase through the full duration of the multi-year project. A pool of prospective evaluators who are skilled in empowerment evaluation, often referred to as EE, are recruited by foundation staff, and they pair up through a speed dating process when project directors and evaluators select their partners. Dr. Wandersman is also one of the creators of EE. It is an approach that aims to achieve results by having evaluators engaged with program stakeholders and providing them with tools to assess their planning and implementation, often mainstreaming evaluation throughout the organization. This differs from the traditional evaluation approach, where a PhD evaluator arrives after the project concludes to try to discern if the program made a difference. That's like training and using MDs to only do autopsies. The empowerment evaluation approach extends the PhD evaluator's expertise in research design, data collection, and reporting throughout the life of the project, not just doing a post-mortem after the grant ended. So EE is more like using MDs to help prevent and treat illness. Dr. Wandersman and his colleagues further developed this model known as Getting to Outcomes, and it received the American Evaluation Association's Award for Outstanding Publication in 2008. Getting to Outcomes is hosted for free on the RAND Corporation's website and has been downloaded more than 250,000 times. The Health Foundation's support for the Worcester Initiative for Supported Reentry, called WISER, provides a good example of the value of engaging evaluators throughout the project. The goal was to improve public safety and public health by reducing the recidivism rate. The intervention provided those exiting incarceration with health care and social services and housing and employment assistance. The recidivism rate among WISER participants 3 years post-release was reduced by 47% relative to a historical comparison group provided by state data. The intervention produced a 59% return on investment based on 1-year incarceration rates. With this significant data, the state began in 2019 replicating the model in 2 pilot counties and continues to expand the services by providing $11 million thus far. The Health Foundation had invested $2.3 million in the project. Consideration 5, support advocacy that leads to systems change. With evidence of effectiveness of grant interventions, it is incumbent on funders to also support advocacy efforts that lead to policy changes in order to sustain the intervention after the grant concludes. Without this final step, it seems that philanthropy ends up having to continuously address the same health issues, often with the same interventions, somewhat like reinventing the wheel. Like most conversions, the Health Foundation retained its health plan predecessor's 501c4 tax status, and we were fortunate to convince the Attorney General and Probate Court to allow us to support advocacy and lobbying efforts at the same level as public charities are allowed. While private foundations are restricted from supporting lobbying per se, I encourage the field of philanthropy to deeply explore the fine line between advocacy and lobbying. Adoption of policies that sustain effective grant interventions can be achieved without crossing that line. I was pleased to learn that GIH's new strategic plan seeks to sharpen its focus on leadership and influence through the use of policy and advocacy. I encourage GIH to consider facilitating our members' exploration of how to effectively support advocacy efforts. Once we are knowledgeable and comfortable adding that component to our philanthropy, GIH could then survey members to help identify one common national health issue, an issue for which funders across the country could contribute some resources to GIH. GIH could then deploy these pooled resources to orchestrate the formation of a broad-based collaborative of organizations beyond philanthropy who have a deep and long-term shared interest in the issue. GIH could also convey funding to leading organizations for the research, planning, and implementation of an advocacy campaign. Perhaps establishing universal access to health care in the United States could be such a worthy endeavor. Thank you. A national advocacy campaign on a prioritized health issue will require boldness and acceptance of some risk in the reach for better philanthropy to achieve better health. When I was finishing my master's degree at the University of Georgia in 1972, I felt called to save our youth and accepted my first professional job as a high school teacher in a rural Georgia community. Hoping to inspire my students as it did me, one of my first bulletin board creations in my classroom was Robert Browning's line, "Ah, but a man's reach should exceed his grasp, or what's a heaven for?" By my second year on the job, I realized that the educational environment desperately needed a systems change. Indeed, my advocacy on behalf of students resulted in the principal, a former math teacher, dubbing me the Don Quixote of Elbert County High School. I figured that if I was to have an impact on the system, I would need a terminal degree and I would need to be superintendent. So I returned to the University of Georgia to earn a doctorate in education and then went on to teach and serve as an administrator at the University of South Carolina at Spartanburg before I entered the field of health philanthropy. I played a visible role in the university's fundraising campaign for its School of Nursing, which caught the attention of County Council, who appointed me in 1983 as its first woman trustee at Spartanburg General Hospital. I was immediately fascinated by the complexities of healthcare and became active in the South Carolina Hospital Association. The cost of healthcare at that time was rising dramatically, and the association decided it would help its image if they created a public relations diversion. They settled on a campaign to make South Carolina hospitals smoke-free, and they asked me to lead it. Our father, a heavy smoker, had recently died from lung cancer at the age of 62. Please recall the context at that time. Smoking was allowed everywhere, in restaurants, in bars, in schools, on airplanes, and of course, in hospitals. Lung cancer was the leading cause of preventable premature death. We have very few pictures of our father without a cigarette in his hand. He was in the Army for 30 years, served in World War II, Korea, and Vietnam conflicts. Cigarettes were included in the mess kits, sold at a discount in the commissary and post-exchange. I accepted the smoke-free challenge because I felt that our society needed a cultural change and that the healthcare field was best positioned to take the leadership step. Surely other sectors would follow. This 2-year campaign was the most challenging of my life. Hospital administrators wanted to do the right thing, but at that time, many doctors and nurses smoked, and many threatened that they would not admit their patients or would quit working at the hospital. Some doctors owned tobacco farms or rented their land to tobacco farmers. Recognizing that the barrier of competition for patients and nurses had to be overcome, we understood we needed to take one hill at a time in the battle. So we brought together all the hospitals in a shared market area, and they agreed to go smoke-free on the same date marked by a joint public announcement event. South Carolina became the first state in the country to have its hospitals voluntarily go smoke-free in 1989. I recently retired and moved back to South Carolina. Earlier this month, I visited a dear friend who was hospitalized at Ann Med in Anderson. As I approached the entrance to the hospital, I noticed signage that designated the hospital and its entire campus as smoke-free. A profound sense of peace came over me as I reflected on the full impact of that system's change. So for 50 years, I have been inspired by Browning, striving to reach beyond my grasp. And although I may not make it into heaven, and you may not either, I encourage GIH and health funders to take up the challenge of reaching beyond your grasp. Thank you.
Please join me in just giving another hand for Janice, and I just want to share, this is the award that she will be taking home. So I'm really touched by Janice's comments. It reminds us of what we have accomplished, and it's so hard to remember those moments of real victory. And so my heart to you for the long battles that we all fight and the victories that you've won. So thank you. So I'm Laura Landy, my name was up there somewhere. I'm the president and CEO of the Ripple Foundation and a GIH board member. And it is my distinct honor today to introduce Evelyn Delgado, who is sitting over there, who is this year's winner of the Andy Hyman Award for Advocacy. And this is the Andy Hyman Award that Evelyn will be taking home. The award is unlike recognizing a foundation. This is an award given to an individual, a grantee, a member of our community, somebody who shows up as an exemplary steward who's shaping our future on the ground every day. In today's truly divisive and challenging environment, we need stewards like Evelyn. As president and executive director of Healthy Futures of Texas, she works to reduce teen and unplanned pregnancy in San Antonio and soon across the state of Texas. So I want to repeat that so we all take that in. She works to reduce teen and unplanned pregnancy in Texas, now in a post-Roe environment. With the award criteria including a demonstrated commitment to principled action, leadership to advance social change, and dedication to making progress and practice despite challenging political environments, there could not be a better choice for today's award. At Ripple, the operating foundation I have the privilege to lead, we recognize the power of people like you, Evelyn. You are what we call a steward. Building on decades of experience, we work in partnership with communities, with healthcare systems, with corporations, with government agencies, and with cross-sector coalitions to focus on how they can achieve the equity-focused change that we all need in real-world settings, similar to the work that Janice was explaining. Our movement strategy, and it is about building a movement, is to cultivate and support a growing cadre of stewards, real people in real places who appreciate that the goal of thriving together is bigger than themselves or their own organizations, that, we support them to engage across sectors, to build new mindsets, to co-design new actions, and to shift investments, all to eliminate inequities and advance the vital conditions everyone needs to thrive. Over the years, our work and our work with communities and individuals across the nation has revealed strategies that span political beliefs and respect regional differences and community needs, and honor the things that all people, despite political beliefs or state voting practices, all want in terms of having lives that are healthy, respecting well-being, and thriving. Andy Hyman and Evelyn Delgado stand out because they embody the skills and characteristics of effective leaders and stewards, and they inspire us to follow their example. Andy Hyman, who this award honors, was a government official, a healthcare advocate, and a philanthropic leader who died in 2015, way too young at the age of 49. He worked at HHS under the Clinton administration. He was a leader for state mental health program directors, and later spent many years at the Robert Wood Johnson Foundation, who also supports this award. While Andy did great work everywhere he went, it was his driving passion that was so memorable. He wanted to ensure that everyone in America, especially the poor and underserved, had the coverage necessary to access high-quality physical and behavioral care. He also wanted to be sure that representatives of the community had seats at the tables where decisions are made. And I kept hearing, he wants to be in the room where it happens. I can't get that out of my head while I'm talking about it. Among his many civic activities, he was dedicated to an organization promoting the health and well-being of young people, and where, by coincidence, my daughter went to get her first birth control while she was still in high school, and which her father does not yet know about. It's true. Evelyn Delgado could not be a more perfect choice to honor Andy's legacy. We owe her selection to Lourdes Rodriguez of the St. David's Foundation, who nominated her, and to a dedicated GIH committee that includes Gary Nelson, David Adler, Ryan Barker, Carolyn Brunton, Tiffany Donaldson, Elizabeth Krause, Eugene Lewitt, John Lumpkin, and Lisa Shapiro. Please join me in thanking them for their service. Not only does Evelyn echo Andy's interest in reducing teen and unplanned pregnancy, she does so in Texas, making progress in a challenging political environment. Like Andy, Evelyn also spent time in government, 22 years including as Associate Commissioner of the Family and Community Health Services Division of the Texas Department of State Health Services, which she had to fit on a business card at some point in her life. In moving to the nonprofit sector, her goal was to bridge the lessons learned in government with the opportunities she saw in communities, to bridge those and make them even stronger. She now chairs the Texas Women's Health Coalition and represents the interests of women in color in multiple working groups and coalitions, including the American College of Obstetricians and Gynecologists District Council. While Evelyn has a long list of accomplishments that deserve to be celebrated, it's how she accomplishes what she does that's most important to her success, and where we can learn important lessons. She has a deep commitment to system change. She knows how to bring others together to shape efforts that shift the system as a whole while still addressing the symptoms that she confronts every day. She leverages her own diverse experience to help enable people to hear one another and to find their common ground. And she is currently leading an effort to bring several organizations across the state together into a single structure to ensure that they have even more effective service providers and more effective advocates. Most importantly, Evelyn brings her life experience. She brings her passion for everything into everything she does. She is a hero, a selfless model, a contagious spirit, and a joy to be around. So it's my pleasure to introduce you to Evelyn Delgado, the 22 recipient of the Andy Hyman Award for Advocacy.
Thank you to Grant Makerson Health for the Andy Hyman Advocacy Award, and to the Robert Wood Johnson Foundation for sponsoring it. Thank you to St. David's Foundation, our colleagues in this work, and to Dr. Lourdes Rodriguez, Senior Program Officer, for the lovely nomination. When I was just 8 or 9 years old, my mother would take me to the neighborhood community center. As kids, we went there to get shots for school. It was a small one-room building where I helped my mom distribute food like cheese and dry milk and pass out donated school supplies. But my most memorable job was helping Mom with adult literacy classes. I realize now my mother worked as a promotora, or community health worker, back in the day before they were called that. Even though she missed many days of high school helping my grandparents in their migrant work, she was able to graduate high school. She used that knowledge to serve her community. There was one person at the center whom I remember vividly. His name was Pilar. I remember the way he dressed and talked, and I remember that he showed up every week to the Villa Coronado Center. Pilar was a young man who had difficulty speaking English. I still admire his resilience and the persistence it must have taken to show up at the community room in the evenings, week after week, to learn to read. My mom was his teacher, and I realize now that in a fundamental way, I was learning what it meant to teach, what it meant to help people access food, health, and education. That's where my advocacy journey began. My life's journey took me from that community room to Trinity University in my hometown of San Antonio. It was so expensive, we couldn't afford it. It was a rich kids' school with few Latino students, despite sitting in the heart of a city with a large Latino population. But my high school counselor, who went to Trinity, convinced me to go there too. She was disappointed I didn't apply to Harvard or Yale, but I wanted to stay close to home. I was only 17. All my life, I remember my parents saying I had to attend college, and I had to make good grades to get scholarships to pay for it. My degree in business administration ensured the security that my parents hoped for. I began a career in accounting, working at Southwestern Bell. I was in accounting and finance for many years, loving that job, before getting a job as a state budget director. It led to my first advocacy adventures. During those 5 years, I used that budget director position to visit program sites, to learn firsthand how human services are provided. I remember being in food stamp offices and watching mostly young moms with their kids applying for benefits. I visited with Child Protective Services workers and went on family visits. I learned about adult living programs for foster teens aging out of the system. These experiences transformed the direction of my career. I knew I wanted to serve people through programs. I did this when I became regional director over long-term care regulatory programs, overseeing facilities at 28 South Central Texas counties. I advocated for the health and safety of the elderly and disabled. I was fighting the good fight, and it was so satisfying to ensure that the elderly and the disabled were safe. After serving 28 counties, my new goal, was to be the Assistant Deputy Commissioner so I could have statewide impact. I didn't think I could do it soon because I had more steps in the org chart to go through first. But Executive Commissioner Ann Sapp, who I will always remember, took me aside. She was one of the only people of color on the leadership team. She encouraged me to go for it. So I skipped steps and became the Assistant Deputy Commissioner of Long-Term Care Regulatory Services for a few years and did what I loved. My next opportunity was the most special of all at that point, to serve as Assistant Deputy Commissioner at Texas Department of State Health Services. I oversaw 450 staff and a budget of $980 million. I went into this position without public health experience, but I knew state government, how to navigate the legislative process, manage large budgets, and run statewide programs. Our programs were family planning, breast and cervical cancer, adolescent health, programs to address infant and maternal mortality, and the WIC nutrition program. We helped uninsured and underinsured families live healthier lives. In Texas, 3 out of 10 women have low incomes, and 1 in 5 lacks insurance coverage. Medicaid is mainly available to Texas women only when they're pregnant. Unless they qualify based on a disability, after short-term postpartum period, few remain eligible for Medicaid. And even if they know they're eligible, the system is really, really hard to navigate. It was our job to help. Our division created policy, delivered programs, and educated the public. In my role, I also served as an expert witness to the Texas legislature. I found that I could advocate internally by presenting the best options for managing the federal and state dollars that fund these essential programs. I made sure we spent state money to prevent unintended pregnancies and promote healthy ones. In Texas, about half of births are unplanned. Half of all births are paid for by Medicaid with a state funding match. Each of these births has its own impact, not only on the physical health of the child and its family, but also on the state's budgetary health. As a state government executive, I learned to use my government and policy knowledge to help advocacy organizations understand where the opportunities lie and where there were barriers to success. Notice that I call it educating, not advocacy. It's a fine line I adhere to as a government employee, and one that is important for foundations as well. It's important to understand the timing of government funding and policy decisions and key points to the legislative process, to know which legislative offices are committed to women's health, which are a maybe, and which are a definite no, or maybe even a hell no. I don't know, I shouldn't have said that. It's never been easy to navigate these systems. Even as a state employee, we were handed very difficult situations by the legislature. So I educated organizations seeking state funding on how they could navigate the systems. I remember when a breast cancer advocacy organization planned to ask the legislature for $1 million for more screening, diagnosis, and treatment services. The timing and the legislative climate seemed right for them to be successful, but their implementation plan needed work. After providing some education, the organization modified their plans and moved forward with their ask to the legislature. A month or so later, when the legislators asked how the state would use the funds, if awarded, I already have my answer. In fact, I had a perfect answer on how to spend $1 million. We all won. The women receiving breast cancer services, their providers, the advocacy organization, and my program's reach. These are the gymnastics of Texas women's health policy, and when it works, it pays off big time. Advocacy in women's health becomes more challenging when we stop talking about breast cancer and we start talking about contraception, or when Planned Parenthood's name comes up, or when people needing care are not citizens. It's a whole different ballgame. In 2011, the Texas legislature slashed the women's health budgets by 2/3. $36.7 million. Can you imagine? 2/3. And it was a complete surprise. Somebody let it be known at the Capitol that legislators could come to the budget amendment filing process and take money from family planning through a technical measure. Legislator after legislator came to the podium to propose moving another several million dollars away from our programs, and it happened all evening long. By morning, $36.7 million of our budget for women's health was gone. The result? The result was 82 clinic closures in Texas. Clinic hours and services were reduced. Access to the most effective forms of contraception were decimated. There were drastic consequences, like a domino effect. Women had difficulty accessing services, the number of unplanned pregnancies increased, as did the number of abortions in Texas. Not only were health outcomes impacted, but the state budget felt the consequences too. We know from the data that it costs far less to provide family planning services than it does to pay for labor, delivery, and postpartum costs, and medical costs for the infant's first year on Medicaid, not to mention the cost of raising a child. Unfortunately, the legislators making budget decisions that evening must not have understood the fiscal or the very real personal consequences of these decisions. Texans took action. Women's health providers or leaders founded the Texas Women's Healthcare Coalition to ensure a statewide organization was at the table to strategically advocate for access to preventive health care for women, including contraception. Little did I know that eventually I would leave state government and become chair of that very coalition. While we have seen funding increases over the years, we're just now catching up to the funding we lost over a decade ago, and demand for services has increased significantly in that time. There continue to be significant barriers to accessing women's health services across the state, and the work has become increasingly complex, from monitoring state budgets to all kinds of battles about requirements for providers, policy language, and just access to services in general. Today, as chair of the Texas Women's Healthcare Coalition and executive director of Healthy Futures of Texas, I advocate for lawmakers to fully fund women's health programs, to make statute changes that can improve services for hundreds of thousands of women. Advocacy for women's health issues is hard. In Texas, it's exponentially hard. Every year, women's health advocates struggle to just retain current funding levels and meet the demand we know exists. There are 1.8 million women in Texas who desperately need preventive health care services. We're facing extraordinary challenges, but we can't give up. We aren't just trying to catch up to the states that do things well. We want to lead. We are collaborating with partners across the state to do just that. Healthcare access is only one piece of the puzzle. Education is also critical. In fact, Healthy Futures of Texas' roots are based in sex ed advocacy and delivery of sex education. This may come as a surprise, but we recently made progress advocating for medically accurate, age-appropriate sex ed in Texas. Woo! In 2019, the State Board of Education began updating the health curriculum standards for the first time since 1997. Since 1997. This presented a rare opportunity to change sexual health education for all 5.4 million K-12 students. Together with our two partners, the Texas Campaign to Prevent Teen Pregnancy and the North Texas Alliance to Reduce Unintended Pregnancy in Teens, we built Texas is Ready, a campaign to improve school-based sex ed in public schools. We took huge risks together to support improvements in the statewide standards. Each of the three cornerstone agencies immediately redirected staff and funds to respond to the opportunity to revise standards. Innovation and responsiveness played central roles in our advocacy. We put aside our individual strategies to invent and implement a common strategy, which served as a critical force multiplier. We built a robust common media strategy that blanketed Texas in positive news coverage. We blended our staff to an unprecedented degree, building links between direct service staff all the way up to the C-suites between the three advocacy organizations. We engaged powerful allies across the state, like the Texas Medical Association and a group of influential Republican women. We empowered youth to play a critical role as well. I remember the brutally honest and incredibly courageous testimony of some of our Youth Advocacy Council members so vividly. The Texas is Ready Coalition's work provided an essential, data-driven, nonpartisan resource for the State Board of Education and for advocates. We engaged all 15 board members, 10 Republicans and 5 Democrats, to hear their priorities and educate them on their issues. Very few members were familiar with current rates of teen pregnancy or STIs, or evidence-informed strategies to address teen pregnancy. Our approach to meeting the specific concerns of each member created essential consensus on key components of the new standards. And it worked. Now, we didn't get everything we wanted, and we're continuing to advocate for higher quality sex ed implementation, working with local communities across the state. The new and improved standards go into effect next month. With the 2022-2023 school year, and include information on contraception and STIs at the 7th and 8th grade levels for all Texas public school students. This is in alignment with recommendations from physicians, researchers, and other experts. This change provides the opportunity to reverse negative adolescent health outcomes in the state at a scale previously unmanageable. Before this revision, only an estimated 16% of more than 1,000 Texas school districts offered effective sex ed. Our success was only made possible in partnership with funders who were ready to be our safety net and to shift strategy with us. We could not possibly have known that this opportunity would present itself in time to write grants to prepare for it. And yet now, every Texas student will have the opportunity for school-based sex ed. Texas is Ready supports school districts and charters to implement the new standards, and ideally, stronger sexual health education curricula on campuses across the state. While I am grateful to all our funders and everything they offer us, I wish more were able to respond alongside us, because the investments we need will continue to be a need. Since the new standards passed, the Texas legislature passed other legislation requiring parental approval for any sexual health instruction, making Texas one of only 7 states in the country to have such a policy. We have work to do when the legislature convenes again in January. This kind of intensive, responsive, systems change work doesn't fit easily in grant applications sometimes. The dreams for the youth, women, and families we serve are big, and the challenges we face are unpredictable. When I review grant opportunities, I'm not sure where Texas will be the leader in women's health and sex ed actually fits in just right into the boxes. But that is my goal. That is why I'm here. I want you to know that you can trust us. You can trust our communities and our partners. You can rely on us to lead. Just like my mother all those years ago stepped in because it was the right thing to do, we too can step in. The fight is not getting easier for nonprofits. Each day brings new obstacles we couldn't have imagined the day before. Our systems are destabilizing, but instability creates opportunity. I ask you to consider if the way you invest funding is prepared for these instabilities, because it isn't just women's health funding under threat. It's the financial health of our nation. It's the financial health of the companies in which you invest and the communities you serve. We are an ecosystem together. Healthy Futures is a nonpartisan organization that does not take a position on the issue of abortion. Our stakeholders have feelings on all sides of the issue. We work to build consensus among a broad group of stakeholders who can all agree on the importance of preventing unintended pregnancies. We are all working to ensure that all Texans have access to sexual health education and contraception. The Texas legislature restricted abortion last fall to pregnancies at less than 6 weeks. We have seen over several months what the rest of the country is seeing now in terms of clinics closing and significant political and cultural upheaval. Like many other states, Texas has a trigger ban in place, so abortion will be eliminated completely as a result of the Supreme Court's decision. For us in Texas, there is no choice. We must be ahead of the game to ensure that people have the resources and knowledge to prevent an unplanned pregnancy. There are significant disparities in the access that disproportionately affect populations with the highest rates of teen births, including people of color, those experiencing poverty, those with a history of trauma, those living in rural areas, and those who have had a previous teen pregnancy. It will take intensive and intentional collaboration to close these gaps and to increase access to effective sexual health education at home, at school, and in the community. We must also increase access to sexual health services, including contraception, through both policy and practice. We know recent decisions could affect other rights that are currently in place, including access to contraception. We and our partners are monitoring the situation closely and preparing to defend access to contraception if needed. I am so deeply honored to have received this award. My sister and niece are here today to celebrate with me. My mother, unsurprised. I am so honored, and I know that this honor and this platform today comes with responsibility. So here's the ask. I must ask you, as you return to each of your communities after this conference, to think about this. How can you make it easier for your grantees to do the right thing, because doing the right thing is getting harder to do. I ask this of you because I acknowledge that, just like my colleagues in state government, there are rules about what you can do and can't do. I know you have the boards to report to, you have investments to maintain, but there's a path forward for all of us to succeed together. Our colleague, Dr. Lourdes Rodriguez, knows that and has made it her business to work in this way. She uses her position at the foundation to convene advocates, practitioners, and researchers. She rallies behind us and encourages to take chances. She says, it's okay if it didn't work, let's figure out why. She knows that implementation is a science, and she is always a helpful thought partner, sharing what she's learning too. She may be positioned in philanthropy, but she is with us on the front lines for women's health work. She knows the grant application doesn't need to describe exactly what we do, but rather what we aim for, because there are so many paths we can follow to get there. She's pivoted with us, and in doing so, she had a hand in improving sex ed standards for all Texas students. Lourdes, thank you for nominating me for this award, and thank you for being the funding leader Texas needs right now, the leader that grantmakers in health needs right now. Thank you again for your time, this award, and for your consideration. And perhaps one final idea. Let's make it a contest. Which state represented here will be the next leader in innovative public health strategies? My money's still on Texas. Thank you.